Right, welcome back to part two of the NHS England board meeting. We're now on item 12 of the agenda, which I will ask Paul Barman to introduce around the 2015-16 spending round.
Thank you. I think I wanted a better build-up to all of the mentions during the rest of the agenda, and then tea and coffee to get people warmed up. Anyway, the main facts and figures on this topic, an important topic for us, I think, are all in the paper, and I'm not going to kind of run through the paper in order, as it were. What I want to focus on is the implications of it all really for us as we go forward, and it links very much back to the earlier discussion about how do we make all this deeply practical and concrete and get on with doing it. So, going to the spending review for a moment, there is, of course, the welcome confirmation that another year of headline preservation of the health in the health spend in real terms is there, unlike most of the rest of the public sector, and there's some very graphic charts that we all saw about that. But the big news in this, as David mentioned earlier, is the creation of the integration fund, the integration transformation fund, if you can have that many nouns together, of nearly £4 billion that's being put together. Just to explain very clearly, there's 1.7 billion of that which is already in the system, where health is already in one form or other supporting the social care system in its various activities. But there is an additional 2.1 billion, a little bit next year and then a lot in 15-16, which needs to be found from existing sources through savings to make that fund a reality. And it's that really which will concentrate our minds, I think, as we go forward, because it's, as you can imagine, a very big ask. Now, we talked about clarity in a large part of the rest of the agenda. The details of exactly how this fund is going to work, what the basis of it is going to be, which section it's all going to be organised under, is still very much being worked through in detail between the two departments concerned. Thank you. NHS England and the Local Government Association. And contrary to the simplistic assumption in this paper, which was right at the time we wrote it, but I think now seems to be not quite as clear, it's not a foregone conclusion that the money will simply go straight across and be held by the local authority. It's much more open than that. The one clear thing is it will be pooled money which needs to be managed within the local health economy by the CCGs, I'll come back to that in a second, the local authorities concerned, and indeed the Health and Wellbeing Board as the unit that brings all that together. There is now, I think, a shared determination that the routing of the funding should be through the CCGs, and that's not an administrative matter. That's really quite an important part of making sure the ownership of this and the ability to influence the way in which the money is spent and the outcomes, which I'll come back to, reflects the locus of the CCG as the local representation of clinical leadership in the health service. So that's important. I would say, though, that until we get complete crystal clarity on how the mechanism of this is going to go, the precise answer to how the accountabilities get exercised in all of this, who exactly is responsible for what the line of sight is through the system, will remain to be clarified. Whatever the legal niceties, though, the one thing we do know is that there are two salient questions that we need to address with some urgency now. The first of those is, what are we going to do with a fund of 3.8 billion which will really make a difference in local health economies? How are we going to get this integration concept moving for the maximum benefit for patients and, dare I say it, also for the maximum efficiency for the taxpayer, because both of those go hand in hand. So there's a really serious piece of work to make concrete what we have been thinking about and talking about for many months, if not years, now. Some of that thinking is represented in the conditions that you can see listed in the document in front of you, which are things which together the CCGs and the local authorities will have to work their way through, but these will be a deeply local set of approaches to it which reflect the local circumstances. So there isn't a one-size-fits-all approach. So that's one of the questions that needs to be answered, and it's the one, frankly, that most people are perhaps focused most on at the moment. Equally important, if not more important, though, is that you can't spend money that you haven't got. So there's a rather thornier question that we need to address, which is, how do we generate savings of £2 billion on top of all the savings we already have to generate on an annual basis to keep going? How do we generate that in a way which sustains healthcare and doesn't cause unintended consequences of a significant nature. So you'll be aware the kind of efficiency level in the system at the moment, the ask on the system, is round about 4 to 5% if you add together the provider and the commissioner ask at the moment. That trips up to at least 6 to 7% when you put an additional ask of 2 billion into the system. And as David has already said, that's a non-trivial ask. It's not just a small adjustment to the kind of percentage savings that need to be done. That takes it into a whole different category of the stretch that is required. It's really quite a heroic undertaking, one might put it, to go back to my earlier comment about finance in a rather different context. The most obvious thing to conclude is that you can't do that by business as usual. You can't do that by salami slicing. You can't do it by incremental gains of one sort or another, and a few of you have mentioned that as we were talking earlier on. If you want to invest cash, you've got to generate it, and that means effectively disinvesting in other activities of one sort or another, and we mustn't avoid that in the discussion that we have. We can't pretend we can just generate the money without making changes. So we're going to have to find some clear strategies, and we here clearly is a local as well as a national we. Some really clear strategies for shifting activity, shifting resource to create that capacity. And equally important, having shifted the activity, we've got to find a way of taking out the cost from where it's currently being incurred. And again, there are complexities in that we're all familiar with. The second thing that's obvious is that if we start planning for that when we get to 15-16, it will be too late to do that, because you can't do that sort of change on a short-term basis. So we've got to start planning now if we're going to free that up for 15-16. And of course, there's a strong link to the call to action that we talked about earlier. This is one of the means by which all of that gets made concrete. We talked about the call to action as being a 5 to 10 year challenge, possibly longer than that in its vision. This brings it very much to a 90-week challenge, and I think we've just got to square up to that quite quickly and work out how we're going to make a reality of that. So what are we going to do about it? To make sure that every health economy is well prepared for that challenge, we're about to launch a process of accelerated planning where CCG teams, area teams and other local partners in health and social care can work together to produce strategic plans which address all of that for the next 5 years. But crucially, some 2-year operating plans, a bit of a novelty for all of us, 2-year operating plans which will make very concrete what are the steps we're going to do in 14-15 and 15-16 to make it real in that short time frame that we've got. They need to be deeply practical plans, and they need to show in some detail how the various parties to that, wherever they sit in the local health economy, are going to contribute to it. One of the things we can do to help with that process is to give some clarity about funding for individual organisations for that 2-year period, because you frankly can't do 2-year operating plans without clarity of resource. And one of the benefits of the 15-16 spending review being there already, and we know already about 14-15, is that we will know by the time we get deeply into that planning process how much money we've got, and we can make allocations subject to the board agreeing that when we come to make the formal decisions on a 2-year basis to give people the clarity to plan by. We're going to put in place a programme of support to commissioners to do this planning, because it's very clear that this goes beyond what most health organisations have been able to do in the past. We'll all be aware from the authorisation process that the one set of criteria which was most frequently a challenge for CCGs has been the planning set of challenges, and therefore putting an additional complexity and length, as it were, and challenge into the planning process, we need to put some support in place to do that. As you'd expect, we're doing this absolutely hand in glove with, is that the right expression? Hand in hand, I suppose is what I mean, with the, it's a different analogy altogether, isn't it, hand in glove? Never mind. We're doing it in partnership with the Commissioning Assembly, which of course is our link between NHS England and the CCGs to make these things happen in a joined up fashion, and we've started that dialogue already with Ros's support and help. We're also in discussion right now with the Local Government Association and with a variety of arm's length bodies, the national partners that we have, whether that be the Trust Development Authority, whether it be Monitor, to see how we can make this a truly integrated piece of planning, because if we do it on a pure commissioning basis, you can't answer half of those questions that I posed at the beginning. So it's really, really important that we have it joined up, and I think there are some good signs at the moment from the early conversations that David has had with anyone else that's called David in the country, and the follow-up conversations that we're having with people who are not called David, just how we might bring all of that process together into an integrated thing, because it's the only way we'll make it stick. So that's really all what I want to say about the planning process. There is one additional complication which is put into paragraph 10, in that at the same time as delivering all of that, we'll have to make some very substantial savings in our admin costs, coming on top of the reductions of 30 to 50%, which we've already absorbed in putting this organisation together, and where we're already trying to make sure that we've got that resource in the right place, in the right measure, and able to tackle the challenge. So if you take those two things together, 2-year planning with an enormous ask in 15-16, and the need to think about what we do with our admin structures, it's a massive test for a commissioning system which, as David has already said, has only been in existence for a matter of weeks. And we haven't got very long to put these plans together because we need to start implementing them soon. I do think, though, if we tackle this with a real passion and determination and support for each other, it will give real impetus to the kind of transformation that we've talked about in the call to action, and will end up being a positive thing, albeit a challenging thing. That's kind of all I wanted to say by way of introduction. I'm obviously happy to take any questions, and as the person that has the unenviable task over the next couple of weeks and months of working out how to do this wonderful planning process I've just described, I'd be really keen to get any thoughts, help, offers, all the rest of it that people around the table can bring to bear as to how we make a success of that. Thank you.
Moira?
Thank you, Malcolm. Thanks to Paul for that very clear setting out of the enormity of the challenge, which I fully accept. But I would want to pay tribute, in a sense, to the recognition that this gives to the importance of social care in the system, and putting money where your mouth is a very important signal, and the stretch in social care that we all know, and having recognition, I, as I say, welcome greatly. But the impact of cuts in local government isn't evenly spread, and there is a risk, in a sense, that it isn't a straightforward replacement for cuts. That's obviously not what is intended, but there will be places that are definitely having more of an impact than others, and how our distribution, the distribution mechanism, will assist or, in fact, potentially, not recognise that. I'm interested in your thoughts on that.
Well, there's a precedent question which comes back to this: how are we going to do all of this stuff? Which is, who gets to decide the distribution of this? And that's one of the questions that we're currently working through. It will be no surprise to you, I guess, to recognise that we would quite think it would be a good idea if we did that particular exercise. That isn't the case with the current social care transfer that we're required to make. But I do think it would be important for us to do that as part of the allocation discussion more broadly, because we need to make sure the total funds get to the right places in the right measure, and we can only do that if we bring together the various strands. So that's my aspiration, Maura. I think it's really quite important that that is the way it gets transacted, but as we speak, I wouldn't say that's in the bag yet.
Paul raised the point that I think is critical, and I think we as a board must wait to see where it comes back. But I'm a simple soul, and accountability has to follow whether you are responsible for deciding on where the money is spent and how it's spent and the outcomes from it. And I will be very keen to make sure that we can see that absolutely direct line of accountability to spend and outcomes. And if we're not having that as a board of NHS England, then I struggle to see how we can then be accountable for the spend. But that's a point you'd expect me to make, and I think we have to hold.
I think in principle, putting the money behind driving outcomes based in the community is our direction of travel, and has to be a really, really good thing to do. So I like that, and if this accepting the enormity of it drives us in the direction we need to do, we need to understand the implications of that. Like, we need to start acting now. This isn't something we started in 2015 or 16. It's going to force some real change, and force some real change very quickly. I'm almost more worried about the admin bit, because it's taking more capacity out of the system. It's taking the capacity to take the capacity out of the system, the brain power of the exec in particular, out of the system. at a time when we're trying to not only establish where we are, but accelerate it, because what this is saying is this is accelerating the changes we need to do. And I'd love to know what, dare I use the words risk assessment, have been put in place, just to think that through, because directionally, love it. I think it's great. It's a really good thing. You know, it'll empower health and wellbeing boards. It'll get people playing nicely together across the country. But if we do it at the same time as, you know, getting rid of all the people who can actually deliver it, would probably be not quite so good.
Yeah, I think that's a really good point, and I think we should ask for transparency from the department about what the risk assessment was on the admin cost, and so we can look at it and test it ourselves to see how that is, as well as, I guess, the conclusions they made about the 3.8 billion. Just to reinforce the kind of point that Paul makes, this 2 billion is on top of the 4 billion we've already got to save. And so it's not, you can't focus on the 2 billion alone, you have to do the whole thing. And I think that's in a sense, in some of the conversations I've heard around, people have missed that point, really, which I think is a really important point. Because it's not that we have £2 billion sat around somewhere doing nothing, it's tied up in services. And the way in which we tackle that is going to be really important. So that's the first thing, just to reinforce how big this is. The second thing is I'm slightly worried that what will happen is we'll get involved in a long and detailed conversation about the kind of technical ways the money flows in the system, when actually the real issue is how do we redesign the services. And I can absolutely see how that, so in any planning system we have, we need to make sure that is forefront in everybody's mind, how we're going to redesign the system. We have to do the technical things, I'm absolutely right, but I just think I can see exactly where people will go in all that, and it's actually the system. And I think, you know, there needs to be real transparency and openness and honesty with the public about what this practically means. And that's why, in a sense, it reinforces the whole issue of the call to action. I mean, if we hadn't have done it, we'd have had to have done it now. I think, you know, so I think it seems to me that's really important as far as we're concerned.
Thank you. Have Victor and Barbara.
Well, I mean, I was just going to echo what's been said by David, actually, but which is that I go immediately to the implications for what happens on the ground in communities. And I guess it drives everything to a point of how do we, in a sense, sign off the process of service redesign around individuals and communities. Because if we don't get that right, then we'll end up either fighting about who owns which bit of the budget or salami slicing, neither of which will work. So for me, the implications are that it has to, are about commissioning actually, and what it drives into the system are processes for understanding what people have got, what they haven't got, what they need, and how we redesign the services to deliver it, and how we involve them in doing that. And that's we're not starting with a huge amount of technical know-how. There's some, but it's not something we've done. So there's a rapid learning curve as to how we do that and how we get the sign-offs all the way up the line. And I have to say, you know, it would be in error to paint a rosy picture of understanding between health and social care throughout the country. You know, what this is fundamentally about is power. And what this forces, whether we like it or not, is a transfer of power, which is not something we've done, you know, systematically, effectively, efficiently in the past. So it's a really serious shift it's almost a paradigm shift forced by the money. But the other point I wanted to make was I am very worried about the implications of the 300 million. It's almost, while it's really important we look at the front line and all that, I'm really keen to know what the implications of the 300 million are on us almost before we start doing the other bit, so we've got a clear understanding about what we can do and what we can't in the fixed period of time.
quite plainly, the aim of this money, rightly and properly, is to support those people who don't need to be in hospital to stay at home, and to get those people who are in hospital and are ready to go home more quickly. But we know from the work we do out and about in the country is that actually, whilst often this is a social care issue, it can almost equally often be a health services issue, in that the right community services aren't in place, the right primary care services aren't in place. And I do hope as we move through the way that this money can be used in its allocation and the way it's looked at on the ground, is that people remember that it's sometimes NHS services that are needed to support these individuals, not just social care ones.
Absolutely right. And.
That we've had very positive discussions so far with local government association about this. I guess you might not find that surprising given the potential investment that local government can share in from this, but they have been a very, I think, honest and serious set of discussions where local governments, not just the officials, but some of the political infrastructure around the local government association have recognised that this is not a financial transaction, but that it is a really significant step towards a shared responsibility, not just to design services differently that will better serve local populations, but then to back that up, not just with the investment, but with the political support that will be needed to bring about some really quite challenging, I thought they will be in the interests of patients and communities, but they will be challenging service changes. And the potential game changer here is this money draws together NHS leadership and political leadership in local government to support those changes, whereas at times in the past, I think it's fair to say local government has felt able to step back and just criticise. And I'm very hopeful from those discussions that this could be a step into a different quality, significantly different quality of collaboration.
Right, I think some really telling points have been made in that discussion. Paul, is there anything else that you would like to come back on what you've heard from us?
I don't think so. I've
Okay.
obviously taken note of the sentiment of the board, if I can put it that way, and we'll make sure that gets worked into the programme. And I've taken on board in particular the admin comments, which clearly will pick up.
Well, thanks for that. And actually, frankly, the capacity issue is, I think, just quite scary, hanging over all of this, on top of everything else that we're doing. Thank you very much, Paul.